One way in which the basal ganglia can be conceptualized in terms of its role in motor activity is that it's sort of a volume control. So it determines how much force is needed in a movement, how strong the movement should be. Lesions to the striatum specifically increase involuntary movements. So for example, the striatum is damaged in Huntington's disease, and if you remember, Huntington's is characterized by this fluid involuntary movement called Huntington's chorea, or like Huntington's dance. As well, Tourette syndrome is associated with damage to the striatum. Tourette syndrome is this neurological and also somewhat psychological disorder where people perform involuntary motor activities. So this could be like a tic, like their face might move, their mouth might move. There's also vocal tics or verbal tics where somebody might shout a word out involuntarily in Tourette syndrome. In contrast, loss of dopamine cells in the nigrostriatal pathway that projects to the basal ganglia can produce difficulty in initiating movements. So this could be stiffness or trouble initiating an intentional movement. Parkinson's disease is associated with damage to this pathway. If you remember, Parkinson's is associated with difficulty in moving, especially voluntary movement, and kind of a rigidity, and what they call like cog-like behaviors where movements are very shaky and non-fluid. Moving on to the cerebellum. If you remember from previous sections, the cerebellum is this small structure in the back of the brain below the visual cortex. Cerebellum means little brain because it looks kind of like a little brain stuck up under there. And their cerebellum is predominantly responsible for acquiring and maintaining skilled motor abilities. Different parts of the cerebellum are specialized. Don't worry too much about the different areas of the cerebellum. Just know that it has topographical organization, so it again has this like homunculus organization where the face is near, or different parts of the face are coated near each other. The limbs and the digits are close to each other, so there's like a little map of a person in the cerebellum as well. One of the main functions of the cerebellum is control over the timing and coordination of movement. So the coordination of movement and correct timing is actually extremely important and rather complex. Our hands have to work in concert with each other. Our fingers have to work together, and even small issues with timing can cause major problems with fluid and coordinated movement. The cerebellum is also part of a system that's responsible for comparing the motor plan from the motor cortex against sensory feedback that comes in from our motor behavior. So for example, if I take off my shoe and I feel the removal of that shoe stimulus from my foot, that's expected. I expect that to happen because the motor plan has been sent to other areas of my brain telling it, expect sensory feedback, you're about to take your shoe off. And so this doesn't come as a surprise to me. So going along with what I was just saying, our brain responds less strongly to the sensory feedback of things that we caused as opposed to the sensory feedback of things that other people caused. An example of this is that most people cannot tickle themselves because the tickle sensation comes from surprise, and we can't surprise ourselves with tickling because the brain expects it. We created the motor plan to tickle, and so our brain already expects it, and we don't get that surprise sensation. In schizophrenia, the cerebellum is one of the parts of the brain that's affected, and this comparator mechanism comparing the motor plan against the sensory feedback is dysfunctional. As a result, many people with schizophrenia, especially people who are actively symptomatic, can actually tickle themselves. They can surprise themselves because this comparator is broken, or at least dysfunctional. And as this comparison is associated with a sense of agency or a feeling of having intentionally completed a motor activity, this dysfunctional comparator mechanism has been implicated as a possible reason that people in schizophrenia have delusions of being controlled by outside forces. So sometimes people with schizophrenia, a rather common delusion will be that the CIA has taken over their body and is causing them to do things. That an alien has control over their hands and that they're not the ones controlling their body. So this cerebellar dysfunction might be the reason for some of those delusions. Moving on to section 4, somatosensory receptors and pathways. Somatosensation is all of the sensory receptors in the skin, muscles, joints, tendons, and internal organs. It's somato means like body, so it's essentially the sensations of the body. This includes the vestibular system, which is in the inner ear and is responsible for detecting balance and head movements. Somatosensory system, as we talked about briefly at the beginning of this chapter, is an afferent system. Info flows inward toward the central nervous system, whereas the motor system is efferent. Information flows out of the central nervous system toward the body. Somatosensory receptors are distributed all over the body and includes two main groups of types of skin. That's hairy skin, which is just as it sounds, skin that has hair on it, or that has hair on some people. People have different amounts of hair on their body. So hairy skin is any skin that body hair can be attached to, has hair follicles, and this is most of the skin on our body. And then there's glabrous skin, which has no hair. There are more sensory receptors on glabrous skin as compared to hairy skin. There are no hair follicles on glabrous skin. And this is areas such as the palm of your hand, the bottom of your feet, your lips, and your tongue. These are areas that we have better sensory reception in. So if you step on something, the palm of your foot, that hurts a lot more than if you sit on something and it hits the side of your leg. There are a number of ways to study the sensitivity of the skin, but one very simple way is with a 2-point discrimination task or a 2-point sensitivity test. And in this, you just use something that looks kind of like a protractor, like you might have used in grade school, and calculate the smallest distance at which a person can determine, based on the sense of touch, that 1 point is being applied to their skin as opposed to 2 points. So this is the 2-point discrimination. So the smaller the distance between the 2 points that you can distinguish as being different from 1 point, the higher sensitivity that part of your skin has. There are approximately 20 different types of sensory receptors, somatosensory receptors in the human body, but they fall into 3 main functional groups. There's irritation or nociception, so that includes pain, temperature, and itch. And there's pressure or fine touch, which is also known as hapsis. And then there's proprioception, which is movement and body awareness. And don't worry about learning all these different types within those categories, just know that there are a range of types within those categories. There are also different durations of receptor responses. So sensory receptors are going to tell you 2 main things about the timing of a sensory event: when it happened and how long it happened. The first type of sensory receptor is the rapidly adapting receptor, which responds to the onset of sensory stimulation, such as putting on a watch. And then the slowly adapting receptor is going to respond for the entire time that the sensory stimulus is occurring. So when you leave that watch on for an hour, it's going to be, the sensory receptor is going to be continuously telling your brain that it's there. Posterior root ganglion neurons carry somatosensory information to the central nervous system. The axons enter the spinal cord. The cell bodies are kind of grouped all together in this little bulge you see in the yellow before the axons are entering the spinal cord. And these ganglion, or like group of axons, are composed of many different types of somatosensory neurons, so it's not all just one kind. A loss of function, so a lesion to the posterior root ganglion neurons, can result in significantly reduced ability to control and perceive different parts of the body, so that can be a really dramatic loss. For instance, somebody can lose the ability to continuously hold something in their hand because they're not getting that sensory feedback from their hand so that they can adjust their grip on the object in their hand. The motor system remains intact, but without sensory feedback, the appropriate motor force cannot be implemented. There's a section in your book at this point about 2 different pathways in the brain. Don't worry about it. Don't read it, absolutely, if it's interesting to you, but I don't want you to worry too much about it because it is a little bit complex, and there's a lot of material in these chapters. So moving on to spinal reflexes. Somatosensory nerve fibers send projections to both the brain and to interneurons and motor neurons in the brainstem and spinal cord. And those interneurons and motor neurons in the spinal cord mediate spinal reflexes. So there are different types of spinal reflexes. The first is a monosynaptic reflex, in which there's a single synapse between the motor neuron and the somatosensory neuron. And this makes it quicker. There's no interneuron to kind of mediate the response. So the example would be if you ever go to the doctor and she hits you on the knee with the little hammer and your foot swings up, this is a monosynaptic reflex. Other more complex reflexes, such as controlling walking or your standing posture, involve interneuron connections. They have a few more inputs that mediate those reflexes. Okay, pain. Pain is, we would typically consider it to be a bad thing, but it's actually necessary to survival. It tells us when we're in danger, when we're injured. If you're interested, there's a range of videos on YouTube about people who are born without pain receptors, typically because of a developmental issue, and the struggles that they have without when their body is not able to tell them when they're in danger or when they're injured. Pain perception is actually extremely complex. It comes from a combination of sensory inputs. There are maybe around 8 types of pain fibers, up to 4 possible pathways of pain information going to the central nervous system. And this is one main reason that it can be really hard to treat chronic pain. Chronic pain, for both doctors and psychologists and psychiatrists, it can be really challenging to have a chronic pain patient because the medications we have are not sufficient, and you get addicted to them, you get used to them. So really can be very challenging to bring any relief to somebody who suffers from chronic pain. As well, there are many factors that can influence the perception of pain, and this includes expectation, so whether you expect something to be painful or not. When you go to the doctor, sometimes they might surprise you with a shot, or with kids, they kind of might not tell them that they're about to give them a shot, and this is one way to reduce the expectation that something is going to be painful. Baseline levels of emotional arousal. If somebody's extremely upset, pain can seem worse than if they're feeling calm or feeling happy, and as well the context of a painful stimulus. One example of a factor that can influence or have an expectation effect on pain is the placebo effect of pain relief, which is you can give someone sugar pills and tell them it will relieve their headache, and typically it will have at least some, it will give them at least some relief, just that expectation that the pill they took should relieve their headache. One of the prominent theories of pain, which is a little bit controversial, there's many different theories, and there are strengths and weaknesses to any theory, but one of the main theories is the gate theory of pain. And in this theory, these 2 fibers, the haptic proprioceptive fiber and the nociceptive fiber, synapse on the same interneuron, so the interneuron kind of mediates the connection between these 2 fibers. The haptic proprioceptive fiber, when activated, can inhibit pain information through the interneuron, so it can inhibit the nociceptive fiber from getting to the brain or from sending information to the brain. An example of this is if you stub your toe or hit your knee and rub it, this can often make the pain, it can inhibit some of the pain. and this would be a manual activation of the haptic proprioceptive fiber. Referred pain is a pain that's caused by internal organs but felt on the surface of the body. A really common example of this is that predominantly in men, heart attack is often felt as shoulder pain. So the pain is actually happening in the heart muscles, but it's referred pain, so people sometimes feel it in their shoulders or in their left arm. There's also phantom limb pain. So individuals who have an amputated limb will often feel sensations in that missing limb. So if someone loses their left arm, they might still feel like their left hand is connected somehow or is present. The central nervous system is still perceiving the limb as present. There's still a part of the central nervous system that codes for the left arm. The sensations may be due to reorganization of the somatosensory cortex. It might also just be random firings. Your book mentions some treatments, and my perception of the treatments is that they, based on the research, they actually tend to have rather low efficacy, but they include things like vibration therapy, antidepressant therapy, stimulation of the spinal cord associated with that limb, and then this mirror box where the existing arm is put next to a mirror so that it looks like this person has two arms, and in some patients that's provided relief. If you're interested, you can see this video on phantom pains. Moving on to the vestibular system. This is the system in your inner ear that's responsible for balance. It is comprised of receptors in the inner ear that detect your body position as well as your head position. So there are two groups of receptors that do this, and they're kind of right there on the cochlea, if you remember from the auditory chapter. There's the first group is the semicircular canals, these little loops, and they're filled with fluid. The movement of the fluid, that when your head moves or your body moves, the fluid moves, and this stimulates the cilia of the hair cells and creates a response. The loops are oriented in the three-dimensional planes, so that movement in any dimension will have some kind of response, will be coded in the brain. And then there's the otolith organs, which contain actually a gelatinous substance as well as a tip of salt crystal. And the movement of this stimulates the cilia of hair cells as well, and also gives information about body position, head position. You might be familiar with vertigo, which is the experience of spinning or the world moving when one is sitting still. And this is associated with a number of different disorders, but when it's pathological, so some people have chronic vertigo, this is caused by dysfunction in the vestibular system in this inner ear. Okay, moving on to section 5, the somatosensory cortex. There are two main parts of the somatosensory cortex, which are both in the parietal lobe. There's the primary somatosensory cortex, also known as S1, and this receives sensory information from the body that's gone through the thalamus, coming up from the body, this afferent information. The secondary somatosensory cortex, or S2, gets information from S1 and has more refined processing of that information, and then it sends information to different areas of the brain, including the frontal cortex. S1 is organized, as many things have been that we've talked about, in this topographical or homunculus manner. So just like the primary motor cortex, if you look at this image on the bottom left, the somatosensory cortex and the motor cortex, which are right next to each other, code for the same parts of the body. The somatosensory cortex, however, represents, actually has 4 little strips that code for somatosensory information from different parts of the body. So the muscles, 2 for the skin, for the slow and fast receptors, and then another one for joint and pressure. And remember that the somatosensory cortex, like the motor cortex, represents the opposite, the contralateral side of the body. Damage to S1 can cause complete and permanent deficits in all sensory functions. So S1 is incredibly important to somatosensory function. and sensory function. Impairments in motor functions can happen as well when there's damage to S1 because of this intimate interplay between the somatosensory system and the motor system. The motor system is reliant on somatosensory inputs. However, the somatosensory cortex is plastic, just like the motor cortex. In this monkey experiment that was described in your book, researchers cut the ganglion cells for one arm, which created deafferentation of that arm, meaning there was no sensory input coming to the cortex from that arm. After several years, the area of S1 that was previously allocated to the arm was now represented the face. So it was a demonstration that the plasticity of the cortex no longer was needed for the arm, so the face took over, and there's a larger part of the somatosensory cortex that codes for the face. Interestingly, we can't ask monkeys about this, but in humans who have had arm amputation, the stimulation of facial skin can sometimes feel like a stimulation of the missing arm, indicating that something similar might be happening as what happened in the monkey brain. And this is called phantom touch, when stimulation of one part of the body creates an illusory stimulation of another part of the body. The somatosensory cortex is also involved in higher level of movement. So if you remember the dorsal stream, which was the how stream, and the ventral stream, which is the what stream, these were two visual streams that we talked about in the visual section. The dorsal stream goes to the parietal lobe, ventral stream goes to the temporal lobe. So information from S1 and S2 are contributed to these two streams as well. Damage to S2, to the secondary somatosensory cortex, can cause what's called motor apraxia, and there's many different types of motor apraxia, but in general is a disruption in the execution and sequencing of different types of movements. So you can see a video, if you like, of somebody with ideomotor apraxia, which is an inability to imagine movements, to motor imagery, to sort of mimic movements. And then a picture here, you can see somebody with motor apraxia is trying to comb their hair, and they can kind of do like the rough movements, but they don't have that sensory feedback, so they're not able to, the comb is flipped over, they're not able to do everything correctly.